Present with our interesting topic on large bore vascular access. I have no conflict of interest to declare. So nowadays, a lot of percutaneous procedures like structural heart disease interventions, percutaneous mechanical support device, and others like electrophysiology are done through large bore sheaths. These devices pose a significant risk of either bleeding or vascular complications, whose occurrence is linked with worse clinical outcomes. So regarding the arterial part, the authors have no unanimous definition. Some argue that it's for equal to or bigger than 9 French sheaths, or others for 12 French sheaths. And about the venous access, this is unanimous for at least 12 French sheaths. Some technical factors to be considered is the targeted vessel, the optimal puncture site and plant, puncture and closure, and bailout management. So a lot of arteries, a lot of veins, a lot of targets, and possible applications to select. Let's begin with the main topic of the talk, the common femoral artery, which is the optimal puncture site due to its caliber and ease of compression against the femur. We all know that we have to puncture below the inferior border of the inferior epigastric artery and above the bifurcation. So 3 zones can be therefore recognized of either optimal, low, or high suboptimal access. A lot of applications like chip intervention, mostly unprotected left main with the insertion of impella, structural heart disease like TAVI, peripheral arterial interventions, percutaneous mechanical support, and congenital heart disease cases, like this interesting case of a successful recanalization of a potent limb to LAD in a patient with a class 4 angina and LVF 30% and severe MR. The key measurements are derived from multimodality imaging, mostly CTA and ultrasound, or any prior procedure like prior angio or DSA. And we have to successfully measure all the important vessels and appreciate the calcification, tortuosity. And how to puncture? Well, the old school fluoroscopic guidance is not suggested. The gold standard is the ultrasound, and we have more sophisticated ways like guide wire guidance or angio-guided ultrasound of puncturing with either a classic Stathogiannis needle or a micropuncture needle. One of the most important topics is the ultrasound as a gold standard procedure. We have to have a good opacification, 2 to 3 centimeters above the bifurcation, slightly dissecting soft tissue with lidocaine injection, aiming for the anterior part of the vessel where it's least disease, and after proper orientation, finally engaging the artery. Always keep in mind that arterial puncture and needle entry points are not in the same level. Now, how to close? Well, 2 percutaneous techniques of either involving suture-based techniques, mostly the pre-close strategy with 2 ways of either standard or parallel orientation with proglides, and plug-based techniques, mostly MANTA for large bore vessel access. Lately, there has been described a new technique called mixed technique in urointervention, which involves a combination of suture-based plus a sheath plus an angioseal in 93 of total cases, which reported the important below 1% complication rate. So US guidance is the gold standard. There are some complications. Either the most important of them involves bleeding, with mild or severe in the forms of retroperitoneal hematoma. We all know that occurs within the first 3 hours with a common dented bladder sign. And what to do is based on the hemodynamic status, whether there is active bleeding or not, and whether the patient is in the cath lab or not. We have the pseudoaneurysm with a to and fro flow and deuce, the AV fistula, lower limb ischemia after prolonged impella insertion, retrograde dissection, and rarely nerve injury and infection. So we have some bailout strategies involving percutaneous closure with prolonged balloon inflation, nitinol or cover stenting, like in these cases where prolonged balloon inflation was enough to seal the perforation, or here with a cover stent, and then when everything fails, we have to get a vascular surgery on site. The second most common is the axillary artery for patients unsuitable for transfemoral TAVI, up to 15% in the literature, involving mostly balloon expandable valves. We have to aim for the mid segment where it's compressible, there are no branchial plexus, and good collaterals for the supplying the arm, for mostly TAVI cases, or when support is needed for at least 24 hours. It's relatively free of disease, and it can be a good option in extreme obese patients and offers shorter immobilization. The third artery is the common carotid artery, in extreme cases mostly for TAVI. The left one is selected. We have also other indications like TCAR of a 10 to 8 to 10 sheath inserted. Subclavian artery as another alternative access, where the left is also preferred. Some things to consider is that it should be punctured at its continuity to axillary artery, mostly for TAVI and for support. And we have to do proper measurements on CTA involving the angulation of the aorta and the caliber of the vessel. Now the final part of the veins. The most common is the common femoral vein. A lot of interventions, a lot of endovascular applications. The whole Congress is committed to speaking about this, like TEER, like interventions for stroke, percutaneous mechanical support, congenital disease, or even electrophysiology. Again, the same principles for the artery are applied here. We have to puncture at the plant site before bifurcation, but it may be a little less lower than the artery. And we have three techniques regarding the closure: either manual compression, which is not suggested and not that effective in sealing large bore sheaths. Two strategies involving the subcutaneous sutures of either figure of 8 or purse string. And the final, among the FDA-approved devices, only the angioseal for sheaths up to 29 French. We have some disadvantages and complications as well, up to 13 in the literature, mostly coming from accidental damage of the femoral artery. Other vessels, like internal jugular vein, can be also utilized for either percutaneous support, like the Protect Duo device. This is a slide that sums up all the possible combinations regarding VE ECMO and VV ECMO and the necessary sheaths that are needed to be inserted. And with this, our take-home messages are: technology is here. A lot of percutaneous interventions are nowadays done this way. So this involves dealing with complex substrates, frailty, and sophisticated devices. So adequate training is of vital importance. Multidisciplinary team is the way to go. Pre-procedural planning with respect to CTA is always of vital importance. The micropuncture US-guided technique can result in fewer complications. Vascular devices that are used to seal are not event-free. And we have to be reminded that whenever a complication is on site, we have to be fast and accurate of either percutaneous, and when this is sufficient, always a vascular surgery on site. Thank you.
Thank you very much, Dr. Toulgaridis. Congratulations, nice presentation. One question. Do you have data regarding comparison MANTA and ProGlide, and in which case you use MANTA and which ProGlide?
Very interesting question. I think they're more experienced than me, and the interventional cardiologists that are involved with heart failure or with percutaneous mechanical support. There is a large trial named in Eurointervention Multiclose, which compared this. They're generally safe. They have approximately the same range of complications. There are some pros and cons regarding either MANTA or ProStyle, but it's on the discretion of the interventionalist whether they can use both of them, one of them. For example, let's say MANTA, we don't need to do any pre-treatment. We just have to measure how deep is the depth and then close successfully. But it's maybe more embolic, some argue. Others say that it's time to change from the standard to pre-close strategies. It's still debatable, I believe. But on the final analysis, it's based on the familiarity of the interventionalist and the whole team.
Okay, thank you. Any comment?
excellent presentation. I remember the days of ProStar, because at the beginning of the era of TAVI, ProStar was the only device that can be used. And these devices are very easy to perform, very easy to use. And I remember the days of ProStar with not a very good sense of memory. Thank you.
Thank you.
From online, Dr. Dri and Dr. Janis, any comment, any question?
Good evening. I would like to ask Dr. Toulgaridis which is the more common technique they use for the puncture. Do they use the echo or perhaps angio-guided puncture?
Yes, thank you. It has to do with the setting in high-volume centers. For elective cases, I think 99% uses echo, and there are some few interventionalists, even from the old era, that are based only on angio or fluoro. And it has to do with the setting because this is not always the case for cardiogenic shock, where large cysts are needed to be inserted in a small amount of time. So then maybe anatomical landmarks is the way to go.
Thank you very much, Dr. Toulgaridis.
Also from me, one comment.
Okay. Yeah.
Congratulations for the presentation. I would like also to highlight one more thing to add to the presentation, that sometimes we have also to be cautious for a good preparation of the tissues above femoral artery. That sometimes doesn't seem to be to most interventionalists so important, but we prevent some complications to have good preparation of the tissue and the subcutaneous tissue. Also, we have to keep in mind that the safety wire that seems old-fashioned, we have to consider it in every case because it helps to prevent some complications. And one last thing, I would consider to be cautious with protamine at the end of the procedure, especially in cases that we use the hybrid approach, that we do a suture and angioseal. Because angioseal in small arteries, sometimes we've noticed also in bibliography some thrombosis. So just these 3 comments.
Totally agree with you.
Okay, thank you. We move on to the next presentation.